My name is Paul Siffri with the Stedman Hawkins Clinic of the Carolinas, a division of the Greenville Hospital System. Today I'd like to demonstrate for you a typical knee exam for a patient who is suspected of having an ACL injury. Generally what I do is I have my patient lying down on the examining table. The first thing that I like to do is to routinely inspect or look at the injured extremity. And what I like to do is make sure my patient is in shorts so I can actually observe and inspect both extremities. The very first thing I do is I look for what we call a knee effusion, or swelling of the knee. Oftentimes with an ACL injury, the patient will develop what's called a hemarthrosis, or blood pooling up in the knee joint, evidenced by swelling of the knee. So I'm able to compare the injured knee to the non-injured knee to determine if I appreciate any soft tissue swelling or an effusion. The next thing I do is I inspect the knee for any evidence of prior surgery. I look for scars and any sort of malalignment or alteration in the normal alignment of the knee. Some patients are bow-legged, some patients are knock-kneed, and that's important also to inspect initially when we're examining the knee. After I've inspected the knee and observed for any sort of knee effusion or malalignment, I will next look at the quadriceps muscle, and I will look to see if there's any evidence of what we call quadriceps atrophy or wasting away of the quadriceps muscle. Oftentimes in chronic ACL insufficient knees, patients can develop some quadriceps atrophy over time. Once I've inspected the patient's knee, I will then begin to examine the patient with different maneuvers and different areas that I palpate along the knee. The first thing I do is I'll take the knee through a gentle range of motion. I'll pick the leg up off of the examining table, making sure the patient can get full extension. Some patients may have what we call a flexion contracture, and their knee will only straighten up this far. So that'll be the first thing that I inspect, and I will also compare it to the contralateral knee and note any asymmetry. I will then take the knee through a full range of motion and see how far the patient can flex the knee up. And while I'm doing this, I will ask the patient, does this elicit any pain during range of motion? Oftentimes, if there is an associated meniscus tear, patients will complain of joint line pain or pain right along this area at hyperflexion and hyperextension. The next thing I will do is I'm going to test for the integrity of the anterior cruciate ligament. The first maneuver that I like to do is called a Lockman Maneuver. With this maneuver, it requires the patient be comfortable enough to relax completely and to avoid resisting the exam. Sometimes in an acute injury, it's difficult to do this maneuver. As a matter of fact, sometimes I'll even draw the blood off of the knee joint if there is any, and inject some Novocaine to give the patient some pain relief so they can relax during the exam. I'll now demonstrate the Lockman Maneuver for you. I'll bend the leg approximately 20 to 30 degrees, and I'll put my hand right behind the back of his knee and make sure he's relaxed. At that point, I'll grasp his thigh bone or his femur with my right hand, and with my left hand I'll grab his tibia. And with my right hand stabilizing his femur, I will then pull the tibia or the shin bone anteriorly towards me. And what I'm making sure is that the tibia does not translate too much in this direction. And what I do is do a gentle anterior motion with my left hand, and I note how much it translates and the quality of the end point. And what I mean by that is, does his knee or does his tibia have a soft endpoint or a good abrupt endpoint? And of course, I will always compare it to his contralateral knee. The next test I do is called the pivot shift test. This is a test that's very good to determine whether there's an ACL tear, but again, oftentimes it's difficult to do in the acute setting. I'll now demonstrate the pivot shift test. With the pivot shift test, I will straighten the knee out completely and support the leg with my left hand and ask the patient to relax as much as they can. Then with my right hand, I will put a load or a stress on the outer part of his knee, and then I will put an axial load with my other hand on his heel and take the knee from a straight position to a flex position, and then from this flex position to the straight position. If there is an ACL tear, when we go from the flex position to the extended position, the tibia will translate or shift in this direction towards the ceiling. That is considered a positive pivot shift test. That is highly specific for an ACL tear. The next thing I'll do is have the patient stand up for me and note their mechanical alignment. Let's go ahead and have you stand up there, Mr. Zavala. And I will look at them from the front and note the alignment of their extremity. And again, we talked about whether they have an increase in valgus or being knock-kneed or an increase in varus. And with this patient, he has normal alignment. But if he was varus, his knee would bow out this way. If it's valgus, it kind of knocks in this way. That is the end of the exam for an ACL tear. Ultimately, if we're highly suspicious, oftentimes we will obtain an MRI to determine if the ACL is indeed torn and if there's any other associated pathology.